morning. Thank you for joining us for today's webinar, Pennsylvania OBRA Changes, Best Practices for Efficient and Accurate Reporting. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number, and I will be sending attendance certificates. A survey will be launched at the close of the webinar. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Today's webinar is being presented by Mike Nicodemus with Resolution Healthcare Management. I'll now turn the webinar over to Mike.
Thank you, Wendy. Good morning, and thank you all for joining me today. As Wendy noted, my name is Mike Nicodemus, and I'm here representing Resolution Healthcare Management in our discussion of the OBRA changes that are occurring on July 1st, just a few short weeks away already. As many of you already worked with me in the past, whether that was with case mix or getting your quality measures up to 5 stars or PDPM improvement, etc., you all know that I always have a principal theme. Efficiency is critical, secondary only to accuracy. Efficient systems that produce accurate results solve a lot of problems in our industry. So efficient and accurate data reporting will be the focus of our discussion today in regards to these changes. Let's get started. As noted, Pennsylvania will begin collecting patient-driven payment model, or PDPM, data on OBRA assessments with assessment reference dates of July 1st or later. OBRA assessments affected are the comprehensive assessments, the admissions, annual significant change, as well as the quarterly reviews. Pennsylvania is not alone in this change, as over 30 states are already doing this. The first thing we need to understand is why is Pennsylvania making this change? Primarily, Pennsylvania wants to evaluate the possibility of using PDPM as a new acuity-based reimbursement system for Medicaid. To be able to calculate a PDPM score, they need to add a couple of MDS sections to the OBRA assessments. The added sections are sections GG, portions of section I, and portions of section J. I am very careful not to just call these sections IJ, as I know that that'll trip some of your anxiety triggers hearing those letters together, so we'll try to keep them separated the rest of the way. We want to look today at how do operations need to change to assess for and document these changes, and in doing so in an accurate and efficient manner. We also want to look at what could the secondary long-term impacts of these changes be. Of course, long-term reimbursement, as this is the stated intent of the change, that could very well drive how we get paid in the future under Medicaid. Secondarily, though, what about maybe quality reporting information? The idea of the quality reporting program is to track quality, outcomes, and costs across all healthcare settings. Why not across multiple payers? This change certainly opens up the amount of data that will be available and consistent across all settings for measuring quality reporting. I don't know when or if they will use it, but I suspect it will be used, and probably soon. Food for thought. One of the biggest impacts to these changes is really section GG. So we will have a polling question now. I want to find out how you are currently gathering your section GG information. Wendy, can you share that polling question now? So it looks like our polling is open. Give that just a moment.
Mike, can you see the results now on the screen?
I am not seeing them right now.
Okay. The polling results are, give me 1 second here. It looks like we've got 2% flow records, 14% therapy codes it, 63% combination of therapy and flow records, and 21% for IDT assessment.
Okay, very good. Thank you, everybody. Appreciate the input. Okay, moving on. All right, what does not change? I like to start by alleviating the concerns of those who are prone to panic. I suspect some of you are pointing at each other right now. Am I right? The PDPM HIP scores created by these assessments will not be evaluated by UMR at this time. There is no set schedule to begin that either. Until they actually have some data gathered to make a decision on what the impact will be, there is no plan for UMR involvement. These scores will not drive your reimbursement at this time. So until these things are evaluated and Pennsylvania makes some decisions, and that'll be through, of course, all of the regular legal channels and alerts and question periods and review time, none of this is going to change. We are essentially in practice mode here. And in such, Pennsylvania has made no requirements on documentations of these items at this time either. However, as any MDS item goes, the record should be at the very least reflective of the data recorded. You're going to have to gather this data to code the assessments. We might as well make it easy, efficient, and accurate. And in that effort, it might as well be supported as well. We're going through all the steps and troubles. Might as well try to make it as easy as we can. This is the time we can start creating our best practices and being prepared for any potential impact. All right, as noted, it affects all OBRA comprehensive and quarterlies. We're adding on the needed items to calculate a PDPM score. These items are section GG, self-care and mobility on admission only. Section I with the primary medical condition, that'd be I-20 and 20B. Section J, recent surgery. Coding of section GG is by far the biggest impact to practice changes. Section I and J are going to have minimal impact. Really, the section JJ is what's going to drive the majority of what we need to address here today. The added GG items for self-care are all of these self-care items. There's 7 of them here. I'm not going to read them off to you. I'm sure you can see them just fine, and you probably are very familiar with them already, and if you're not, you probably don't need to be anyways. You have people for that, which is a nice thing. There are 19 items under functional mobility that are added as well. Same idea here. We've seen these before. These depict a resident's functional mobility, and previous, of course, self-care, functional self-care. You'll note that all 26 of these items would apply to any setting, whether they're in a SNF, long-term care, PC, assisted living, home health. All of these items are still relative to a patient's ability to either care for themselves or how much care that they are required. So another secondary thought, could these items help drive the CHC's patient data as to where they should move these patients to the most efficient care settings? We already look at Section G some for that in your standard ADLs, but those are scored in a manner that puts a lot of people in certain blocks and doesn't really clarify how independent people are. Or Section GG, specific to patients' functional abilities, really helps drive a lot more of that data. So another reason why getting this information accurate can be very important to you. So note, I'm not going to show you on every section, but just note that for Section GG, we're going to refer to recording of the admission data. And although we're saying admission, because this has kind of been a retrofit from Medicare to OBRA assessments, admission just refers to the assessment reference period for this time as well. You'll note too at the top of this headings that are now required under the state, it'll say start a PPS or state PDPM, or if the state requires completion, etc. The look back periods for Section GG. For a standalone OBRA assessment, the look back will now be the assessment reference date and the preceding 2 days. This is for OBRA only scenarios. Only the admission performance is recorded. Again, quote unquote admission referencing to the assessment reference date in these scenarios. There is no discharge data required and there are no goals required. When these assessments are combined with a PPS assessment, so if you're doing an admission 5-day, for instance, where you're going to have the data required in for two different reasons, anytime they're combined, you always follow all the Medicare rules. So you follow original PPS rules. So on an admission 5-day, your assessment reference date, maybe let's just say for sake of argument is day 7. Your GG information will be days 1 through 3, just as it would be on a normal 5-day without any OBRA involvement. All other PPS requirements stay exactly the same. Anytime you're combining them, then you are going to have goals required and eventually discharge data required. For coding of Section GG, a key word here is function. How do they function, not what can they do? We want to establish what the resident's limitations are and how they impact their function in an actual day-to-day usual activities. This does allow for any adaptive equipment that the resident may utilize. We don't have to exclude that from the measure of how we're assessing this information. Does CMS subtly hint to a location for providers to find this information? Have we picked up on anything where CMS is kind of driving where they want us to get this information? For those of us who sat through the many CMS trainings on PDPM, over and over and over again, CMS referred to interdisciplinary teams using direct observation and reports from patients, residents, clinician, care staff, family. Essentially, anywhere data is available from to establish a usual level of ability for the patients. Direct observation is not going to be previously recorded. Reports from the patient are not going to be documented. The patient's not going to write this information down for you. The family's not going to write that information down for you. So the only place you could reasonably expect any other documentation to be recorded to the patient's record would be from other clinicians. However, those of you who pulled the answer with getting from therapy and from flow records, I'm sure you run into some of the same scenarios that we've seen trying to do that, where you have a lot of conflicting information. Ideally, when we look for GG information, we're looking for exactly how CMS described it. They're looking through all of the designs for the GG coding are based on the idea of having a collective assessment. We want to code the usual actual performance of the resident. Flow sheets are not necessary and do typically just confound the assessment. Now, I want to be clear, I'm not disrespecting the CNAs in any way and stating that, far from it. My concern is really with a flawed documentation system that we tend to throw at the nurse aides and sometimes other staff member while they're busy doing important work and trying to decide what the difference is between subtle definitions in coding, what's supervision versus partial. Any two people are going to describe that differently, not to mention you have 100 different scenarios across the first 3 days of what the patient's actually doing. Crime detectives often describe how inaccurate witness statements can often be, where you could have 3 people witness the exact same event, describe entirely differently what had occurred, who did what they were wearing, etc. We're not immune to that either. Having a lot of different areas documented may actually cause a lot more trouble than it solves. Best practice has been found to convene a group of clinicians with direct knowledge, discuss each care item as to the usual status, document the assessment period, who is in attendance, and the clinical findings, and specify as the usual performance. Nurse aides, direct care staff, and the residents are absolutely essential to this discussion. Should this documentation match the rest of the record? Absolutely yes. Not word for word necessarily, but it should be enough that you don't think you're looking at two separate patients. One, all the more reason to limit the detailed in flow records because of that, because you will get everywhere from independent to dependent in your flow records. The other place that we tend to have a conflict is in the therapy evaluation, but that's okay. You can have that conflict because the therapy evaluation typically uses different rationale on how they describe their information. A therapy eval is typically speaking to what the patient can do, what they're capable of doing, versus what actually occurs. So I have an example here for bed to chair transfer, and I'm going to call the first way the difficult way. You have a CNA flow sheet. Day 1 lists setup, dependent, and partial across the 3 shifts. Day 2 lists substantial, and supervision. Day 3 lists substantial, dependent, and partial. The therapy eval states, paraphrasing, resident is able to transfer with significant cueing and prompting after multiple attempts. So what do we code here for our bed to chair example? We go with the therapy eval that says that they're able to self-transfer with cueing and prompting, which would code to setup. Do we go code off of how many? There was at least, what am I counting? There are 3 substantials coded under the CNAs. We move to there, we split the difference. What do we code in this scenario? And this is from this is an exact example actually that somebody sent me as a question under PDPM coding. What do we code when we have all these different variables? My answer is throw away that CNA flow sheet. Let's not do that because it complicates matters. The therapy eval, I'm sure, is accurate, but it's describing what they can do. We want to know what they actually do. So in the way that I'll describe as the easy way, that, let's see, going back to my polling question. That's where I write that down. It was 21% using an IDT team, which I describe as the easy way. So you would record that the IDT team assessed resident name from May 3rd through May 5th for their usual performance of self-care and mobility. The IDT team conference included Jen M., the RNAC, Lisa D., the RN supervisor, John T., the director of rehab, Tim T., a CNA, and resident name. Bed to chair, dependent. And you can put optional notes in under each question just to help clarify exactly what was stated or why you made your decisions in any specific examples. So in this case, we might have noted that the resident states, nobody is moving me out of this chair without 2 people. And in this case, the staff confirmed that it usually does require 2 persons to complete the task safely. Have we hit all the buttons that we need to hit here? Let's see here. If I can figure out how to work this now too. Yeah. Oh. All right, we have the time period that we reviewed, who reviewed it, that it was the usual performance, and specifically as to what was coded. So we have hit all the buttons we needed to hit here. The easiest way to put these into place is through a user-defined assessment, and different EHRs may call that a different name, but essentially you're building an assessment specific to your facility that may also write to a structured progress note, which is the most ideal. I'm generally not a big fan of checkboxes because they just don't tell the whole story. The time when I do prefer checkboxes to exist is whenever you need specific items or specific data included in your note. So in this case, we use a user-defined assessment to kind of build a note that makes sure we check all the boxes, as in some snippets here from a couple of examples. Now in this example here, this is a Medicare or possibly a managed care PDPM following insurance. These are associated and tied to our initial care conference, so that we're asking them at the beginning of the stay, and we have the whole team involved. All right. So in this case, this reads to a structured progress note, and this is just a snippet of it. But our review is based on direct observation reports for the resident and staff as the resident's usual performance, assessed through the first 3 days of skilled care. The initial care conference was held on 4/26/21, and the start of skilled care was on 4/23/21. Based on our direct observation reports from the resident and staff as to the resident's usual performance and their discharge goals, admission is a 4, discharge goal is 5. for eating. And we list these all down. And of course, you need to have a key somewhere within the assessment tool as well, so that an end user could establish what it means. Have we checked all of our boxes here? We have our time period. Start of skilled care was 4/23, and it was for the first 3 days of skilled care, so we've defined that. For those of you who've gotten letters from Humana or United specifically stating that you can't support your GG information because you don't have this information or what days they were assessed on, etc., this solves that problem for you. It states specifically that it was their usual and where we got the data from. And again, I didn't include it in a snippet here, but we also list the staff who attended as well. Okay, so noting again, questions that are answered, we addressed who assessed and made the decision. We have a signature signing off as to the accuracy, as well as listing the people who had input. What data was used, a specific listing of what we considered here. We noted the time frame specifically, and we didn't state if it was their highest or lowest, but their usual performance. All right, so if I ask you a question right now, just a total random question, how old was Abraham Lincoln when he was assassinated? How would you find that information out? I don't think we need polling to know that we'll be about 99% Google. The moral of this story is, when you need, what's the quickest way to get an answer to a question that you don't know? Ask somebody who has the answer. Talking to direct care staff and the residents themselves is the fastest and easiest way to obtain the answers to these types of questions. Nobody knows them better, how a resident transfers than the person who's actually transferring them. Now the next barrier. So for those of you who are thinking it or saying it already, but the CNAs and the direct care staff won't attend, don't want to attend, don't have time to attend, etc. I totally understand that they're busy. Being a former CNA myself, I can totally appreciate how demanding their day is. Being a former nurse on the floor, I fully appreciate how demanding their day is. But full and accurate assessment is critical. We can't let an excuse of time or an unwillingness to participate we can't let that be an excuse for not having accurate information to provide great care. This first step in gathering this data is the first step in providing great care for these items. We can't be enablers for them to skip participation. Instead, enable them to be great. Let them know that they're important and you want to listen to them, and make that the standard. They don't need to attend for a long period of time. This could be generally 2 to 5 minutes at the most. And when I state make sure that you're enabling them to be great, letting them know that you want to listen to them. One of my first experiences at a care plan, as a nurse aide, I was called in and asked, how does this person transfer? They transfer with assisted 2, right? And I said, no, I transfer them by myself. And they say, no, they're an assisted 2. I'm like, okay, then why am I here if you don't want to listen to me? I was very green at that time. I didn't understand a lot of things about what was important. Although I could transfer them by myself, 2 people was the right answer. That's how many you should be using, just in case they may buckle, they may fall, etc. Also, the impacts to quality measures and reimbursement. I wasn't aware of any of those things. So getting them involved in understanding the whole process and what all this means and why safety is paramount, this is all important into gaining that. And then they become an advocate for you as well. Early on in PDPM, we kind of looked at the whole section GG information and said, oh, that's covered. We have, doctorates of physical therapy and PTAs and CODAs and OTR. They'll be they'll be evaluating all that. It'll be accurate. We don't have to worry about it. And before PDPM even started, we were kind of testing some theories and going out and evaluating patients and seeing what level of care they were going to give us. And unfortunately, what we learned was therapy is terrible at this. Not at evaluating patients, so don't get too angry with me. Getting their information to what GG is actually asking for. They're two entirely different items. So we had a resident who was listed in our review. Therapy had coded them as partial, moderate assessed. So they needed maybe some hands-on, but less than half a weight bearing. When we had our initial care conference and discussed the GG with the direct care staff and the patient's exact words were to me when I said, it looks like you can almost transfer, but you just need a little help getting up out of, getting up to the chair. And she said, oh no, honey, it takes two of them to get my butt out of this bed. And when we asked the aides, they kind of laughed a little bit and said, yeah, that she typically, we need two of us to get her up and moving. And it's not the therapy doesn't know what they're doing. Of course they do, but therapy says, okay, let's stretch you out a little bit. What we're going to do here is I need you to transfer up. I need you to put your weight forward, but your feet under, no, move your feet underneath you more. Okay, put your hands up here. I'm gonna need you to stay, okay, now lean your weight forward. Okay, let's try it again. Let's try it again. Let's try, oh, there you go. You got it. I had to help you a little bit. That's not usual. That's not what usually occurred. That's what is capable of occurring. And that's what therapy is typically evaluating for. So it's perfectly fine to get therapy's input, to have them do an eval ahead of time. And even if those answers don't match, it's okay because they're really answering two different questions. When you have your ID team discussion, absolutely have therapy there and include their input as to how you're trying to answer these questions. We are always trying to get to accurate, not necessarily to the best possible score. We want an accurate score. We have to consider other things. So in section G, there's other areas where we answer about transfers, and we answer other questions about how does the resident, what's their mobility and how steady are they on their when they stand to make a turn, and do they need staff involvement, or can they do it with able to study themselves? We don't want to have to worry about, well, we made this answer this over here, we want to change that one over there. If we're accurate, we don't have to worry about any of those things. That's what we're always trying to aim for. Okay. The next sections are not nearly as, I went the wrong way. There we go. Okay, so yeah, make sure I knew where I was. My apologies. The next item that changes is section I, the primary diagnosis. The primary medical condition is that is most attributable to the current stay and will correlate to the primary diagnosis chosen. For the OBRA assessments in these cases, it is speaking to the primary diagnosis at the time the assessment is being conducted. So really on the assessment reference date, what is the most direct reason that the patient's in the facility at that time? This will be driven by two items, choosing 1 through 13 as a primary condition and followed up by the ICD-10 code. The RAI manual lists some very specific definitions of all of these, and believe me, you look through them, you will find that some don't seem to go where you might suspect they will, but the RAI does list those all out. All standard diagnosis coding rules apply. You're only going to be adding diagnoses that were active and impacting the patient's care in the last 7 days. Diagnoses must be documented by a physician or extender within the last 60 days. The admission diagnosis does not change over time. However, the primary diagnosis can. Primary diagnosis can change from time period to time period without any concern. There are specific coding conventions that dictate how to choose a primary code. In short, paraphrasing down the short and sweet, the best I can do it, that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Now, I realize that that says to the hospital, but that is the actual coding convention of choosing a primary diagnosis. Then the coding conventions have added that these definitions have been expanded to include all non-outpatient settings as well. So we still apply the same principles, just change the word from hospital. Clinicians have some flexibility in choosing what is the primary. You are typically going to have, especially in a long-term care population, so when we're applying these rules to the OBRA assessments, you're typically going to have a multitude of quote-unquote primary reasons why they're there. There are additional coding conventions for choosing between equally plausible primary diagnoses. As long as you have a defensible position of what you chose as the primary, it should be adequate. So as an example, if you have a patient who's been in a facility for 10 plus years, because they're very debilitated from a CVA, and then something happens where they fracture and they go out and they come back and you're skilling them basically to take care of that fracture and wound care, etc. Can you choose the CVA as their primary? Probably not in that scenario. I mean, you would want to know a little bit more about the specifics. Can you make a good defensible argument? I'm willing to listen, but typically I would say probably not. That's probably going to be skilled under the fracture care. For those of us who are used to coding PDPM and always fearing the return to provider codes, the RTP as they're often referred to, codes designated under PDPM as return to provider will be accepted and then will map to the medical management under OBRA assessments. They've stated that most will. I haven't seen an exact list of any that will not. But for the time being, it looks like they're just going to allow most of them to just map to med management. I would still tend to avoid signs and symptoms codes and use actual disease diagnoses codes whenever possible. And again, always just trying to be accurate as best that we can. Section J adds the beginning portion, well, J2100 through 5000 altogether. Beginning with J2100 is your opening question to open this section. Has the resident had a recent surgery requiring active SNF care? If no, you skip the remainder. If yes, then the type of surgery is answered in sections J2300 through J5000, which is just a listing of all the different types of surgeries one may have had. We're only including surgeries that affect the current status and care planning of these patients. Most surgeries will be resolved in a standalone OBRA scenario because the skilled care is already completed. Exceptions could occur when admitting a straight Medicaid or a private pay patient. I would suspect the most that this will occur is when you're admitting patients on Medicaid managed plans or straight MA admissions. That's where you're going to see them more often. These surgeries questions may actually impact what the documentation you're providing. Otherwise, I just foresee these as having minimal impact to any changes or documentation process. So even though you may code them occasionally on some admissions, it's not changing anything that you're really doing in your operations. New patients being admitted, you're going to be looking over hospital records, coding it as appropriate. Other exception being patient goes out to the hospital, a long-term Medicaid patient comes back without any other payer. You may end up coding a quarterly at that time, capturing some of that care from the hospital for other reasons as well. Documentation highlights. What do we need to make sure that we are considering with these changes? All of them follows PDPM, same or similar processes. By far, the biggest impact, of course, is the GG as far as what your operations will look like. And in that, we want to make sure that we're recording the quote-unquote usual for mobility and self-care scores. Code by committee during the applicable time period. Honestly, it's easy, it's accurate, and it's hard to dispute a room full of clinicians and the resident themselves. I can't imagine a scenario when a reviewer would look back and say, yeah, well, I think you should have coded it this way just on reading the rest of the chart, when you had a room full of people who knew the patient the best and the patient themselves identified as where you're getting your information from. The other advantage to coding by committee, again, for those of you who have known me longest, I always go back to, if you're going to be wrong with friends. If somebody's going to come back and say that you've made an incorrect decision, if it was made by committee, it certainly is a lot more fun than if you're out there all alone. Plan early, tie every diagnosis that you're recording to a treatment and care plan. This is just a great process regardless of payer or scenario. This gets our diagnosis recorded, physician signature, and identifies the impact is evident. And finally, how do we know which items are required under these OBRA assessments? You can always just simply look for the, or if state requires completion with OBRA assessment at the heading of each item. Identifies it right there for you. What is the future of these changes? I assure you PDPM is not going anywhere anytime soon. PDPM Medicaid payment system is expected. You know, we currently have a system with you get one score and one CMI. We average them all up, picture date, etc. We get paid that way. Through PDPM, they could manage this in a lot of different ways, where you could address the PT and OT score, that CMI, the nursing CMI, the NTA CMI, the speech CMI, and they could value and weigh those as needed. Instead of a BAF, we might have an adjustment to those individual components year over year to establish what those costs are, wage indexes, etc. That feels like a much more even way to distribute the funds necessary to provide care than our current system. Quality reporting could expand to all payers. I'm not guaranteeing that. But at the same time, as they gather all of this data and they have it and they can weigh what patients, they already know the patient cost because they're the ones paying the bill. And now they can measure outcomes and quality across all different patients and different payers and different venues and different settings. The age of artificial intelligence is upon us, and this data will be gathered, processed, evaluated, and used to determine where patients need to move to. Performance payments are driven by these elements, very likely. Again, another concept that keeps coming up, wanting to pay based on quality. Well, a lot of these are going to be, at least portions of how they measure our quality. Not just the outcomes, but the patient acuity that risk adjust those outcomes. We can't just measure how many pressure ulcers did you have in your building. Well, what was your payer type? What was your patient type? Excuse me. Do you have a lot of patients who are up walking around doing their own thing, or do you have a lot of very debilitated patients? That's obviously going to change that measure. Regardless of any of these unknown questions, there's no reason not to build an efficient data collection system now. I've seen every which way to gather GG data, and the ones that consistently work the best is that interdisciplinary team discussion. Just make sure that you have all of those checkbox items completed, that we're not missing anything. All right, that gets us through. Do we have any questions?
Thanks, Mike. That was a lot of good information that you shared today. We are open at this time for questions, so if you do have any questions, please type them in the question box, and we'll get to them momentarily. We'll just give it a minute or two to see if we have any questions that come in. We do have another webinar coming up on June 23rd. It's Alzheimer's Association that will be presenting it. And next month in July, we will have our BHSL update with Jeannie Parisi, and we're working on a date for late July, Life Safety Code update with Charlie Schlegel. So keep an eye out for that. And we're trying to get our convention planned, so keep your eyes out for that. Opening registration next month, late next month. And we are open for presenters as well. So if you know any good presenters, especially around workforce issues or any clinical topics, please send them my way. Okay, we have a question that's come in. Let me read it. When answering section GG regarding performance prior to admission for our long-term care patients that have been in the facility for years, how do you answer these questions?
That is a great question. As I recall off the top of my head, I'm not thinking that the prior performance was a part of what was added, but otherwise you would just simply code that. If it was combined or what have you, you would just simply code that as what they were prior to that review period.
Great. And again, if you have any questions, please type them in and we'll get to them. We still have a couple minutes left here in our hour.
And for those of you on point-click care, we actually have the UDAs available. There is a small fee for that, and point-click care charges a few $100s to transfer it to your database. But you can use that process instead of reinventing the wheel to gain that added in.
Yes, the slides will be made available. I will be sending those out in the follow-up email, so you can have access to those once I send the follow-ups. Another question, when do we need to open the start of care functional abilities and goals relative to the end of the OBRA assessment? I'm not sure if that's a typo there.
When do we open?
When do we need to open the start of the care functional abilities and goals relative to the ARD of the OBRA assessment?
Okay, I think what they're asking is just when do they open the review period for section GG, and that would be the 2 days prior to the ARD date. So ARD date -2 is when you initiate the assessment. It'll be assessment reference date, and the 2 previous is the days that you're gathering that data from. You could open it at any time as long as it's specific to that time period of review. And I apologize if I'm not answering that question. I think that's what we're asking.
All right, any more questions? She said perfect, so that answered the question. Thank you, Mike.
Okay.
Okay, any other questions while we have Mike here on the line with us? Otherwise, I will provide his contact information so you can be sure to be in touch with him. If you do think of anything later, I'll have Mike's information in the follow-up email as well. All right, we'll just give it, a couple more seconds to see if any more questions pop up. I'm just going to, again, try to wrap things up here. Just reminder to stay on and complete the survey for us. We do have another question that's come in. Do we need to complete an end of stay functional abilities and goals?
No, you do not. Not for the OBRA changes. It's only specific to the admission, that first column of data. It's only relative to that first column of data. The admission data is all that OBRA requires, and there is no additional assessments. It's just the data added to the OBRA assessments.
Awesome, good questions. Here's another one. How will this affect case mix calculation?
So for right now, it does not affect case mix calculations. That's the $1 million question, well, probably closer to $1 billion question. How will it in the future? PHCA is working with Pennsylvania to try to establish a reasonable and good payment model for Medicaid systems. So as Pennsylvania uses this time to gather data and to kind of, be able to play with numbers and see, ratios of how much they'll be paying. The budget's pretty well capped right now, post-COVID. We're still waiting to see where all the pieces are going to fall on, does our bureaucracy love us or hate us following COVID? Do they realize now how necessary of an industry we are and how bad we're hurting for funding? Or do they just like to beat us up some more? We'll wait and see. But hopefully between those changes, the eye-opening to the needs of the long-term care industry, and with this data gathering, we'll be able to come up with a more equitable payment system for all providers in Pennsylvania.
Okay, here's another question. How do you obtain information from off shifts for GG data?
So a couple of different angles on that. First off, you always can query staff from the other shifts. You can, many RNACs start by 7 or usually earlier, so you can catch midnight crew. Oftentimes staying well past 3 and catch the 3 to 11 crew as well. But otherwise, keep in mind that GG is coded to usual. So if the patient is usually able to transfer with supervision, if they occasionally need more help on midnight, that's really not consequential to the answer.
Okay, we have another question regarding transition. Do we start with any ARD July 1 and after, or does the 3-day period for section GG need to occur entirely in July?
Oh, great question. It's ARD dates July 1 and forward. Whether that, in that case, the assessment period will look back into June, and that doesn't change anything. It's July 1 ARD date and beyond is the critical item.
Great. Again, really good questions. If you have any more questions, we still have a couple minutes left here in our hour. So if you have any questions, please type them into your questions pane and we'll just give it some time. Again, just a reminder that today's webinar is being recorded and will be made available on the PHCA website. And be sure to check out more PHCA scheduled webinars currently planned through the remainder of the summer. Okay, here's a question. I apologize. What happens with July 1 ARD for data collection?
What happens with July 1 for data collection? Do you mean in regards to transmitting, et cetera?
For GG.
So I'll try to answer it in 2 ways. I'm not sure. I'm not 100% sure. So as far as data collection at the facility level from the staff, so July 1 ARD date, you're still going to gather data from June 29th, June 30th, and July 1st. That data will be recorded on the MDS in section GG and will be transmitted and accepted at the state level. I know the state does list warnings. There is a presentation on the Office of Long-Term Living's site where you can look at the exact warning codes for if you don't have data, if you're missing data, conflicting data, etc. Hopefully that answers your question.
Yeah, it says, got it, thank you. So that answered the question. All right, any more questions? These are great questions. Timely, as July is just right around the corner.
So going back to our first question, I just want to clarify. I'm not sure if I answered it correctly. What we were being asked, it was about the prior level of functioning. I answered that as if we were talking about combining it, in which case you answer it the same as you would. Maybe if your question was if it's a standalone OBRA, then the prior level of functioning is not answered as part of these OBRA changes. Hopefully that clarifies that for you.
Okay, a couple more questions coming in. If we only have the UDA for our facility, how is the data plugged into the GG?
So most UDAs, most UDAs that I'm familiar with anyways, give you the ability to flow that information directly to the MDS. So you don't have to be recording it twice. As a general rule of thumb, if you're ever doing something twice on the computer, you're doing it wrong. The one thing computers are great at is redundancy. So you want to build those UDAs so that that information does flow over automatically. And I can give you one other hint in that regard as well. Whenever we built ours, when at the beginning of self-care, it says, what's the most common answer of all these questions? So if they're pretty dependent, you can check dependent and it auto-populates all of the questions as dependent. And then you can go through and say like, well, eating, they're not dependent. We'll change it to setup. And oral hygiene, well, they're partial. So you can then change some of the ones that aren't fitting the common answer. And then again, that just kind of speeds the whole process up a little wee bit. And then if those answers flow over to the MDS, you're one and done. You had to answer all those questions at least once. You've answered them once and you're done. Hopefully that answers your UDA question there.
Okay, so it says, they're saying it doesn't populate automatically. It only does it for PDPM.
You're going to need to look at your UDA then and work on correcting that. You may talk to your specific EHR provider too on what their abilities are. If they have something turned off on that, if there's a way around that, or if it's not, that might be something for them to move up to product improvement.
Okay, that answers the question. Thank you. All right, any more questions? We'll take one more question. We have about 2 more minutes. So if there are any other questions, we'll take one more. Go ahead and type it in. Otherwise, we'll wrap up. Okay, here's our question. You ready? PDPM is being budgeted neutralized for Medicare because facilities still made more money than acceptable to intended. Is the goal simply to drive down reimbursement, not increase it?
Wow, for the last minute question, that one's that's a deep breather.
Loaded.
So I don't understand why CMS put out a system and said it would be budget neutral, and in stating so, make the assumption that they did not assume providers would change anything. Why are you changing the system if you don't think the providers are going to change? The purpose of changing the system was to make providers change, and that's what exactly they got. PDPM has been a great win for everybody involved. Unfortunately, CMS missed by a couple of $1 billion in what their estimates of costs were. Hey, who hasn't been off by a couple of $1 billion a time or two in their life? However, the outcomes that we're seeing out of PDPM are definitely improving. You know, it so much incentivizes us to look at patients early and thoroughly and be kind of that, you know, overview, review of all of the patient's history and charts. And do they still have this? Did that get better? Can we count this diagnosis? And it's all driven by reimbursement, but that's okay. That also gets our goals in line with the patient's goals. So as a patient, I would want them to know everything about my diagnosis history and have it all compiled together. Is their goal to drive up or down reimbursement? I think their goal is to keep it neutral, and it will be long term. But remember, that's not just SNF care. They want to keep people out of hospitals as well, and that's a lot of what PDPM, its purpose is to keep people out of the hospital. I mean, a great portion of its purpose. Mostly we're looking at good care, which drives down cost overall. Yeah, in the short term, they had a bump up, and they're going to drive that back down some with a few adjustments, and they've talked about making that a little bit over time. I mean, there's been several suggestions out there on how they want to do that. We'll wait and see exactly how that transpires. But for the meantime, long-term goal, get the cost of care down overall, including cost of hospitalizations as well. Hopefully that answered that in short amount of time that we had.
Yeah, absolutely. All right. Well, thank you, Mike. Thanks. We really appreciate you being with us today and providing this information. Again, July is coming quickly, so I'm sure everybody is anxious to have more information in order to, get in line with the changes that are coming up. So thank you. Just want to, again, just remind everyone to take the survey as you're exiting, and just want to wish everybody a great remainder to your day and to your week.
Thank you all so much. I appreciate the great questions too. Thank you.